From Imperial College London, welcome to this special lecture vodcast.
It's really a pleasure to be here with you. I undertake this task with a little bit of nervousness because going to another country and talking about one's own healthcare system in the hope of it being useful is a bit of a stretch. You never know if it will indeed be useful, but we'll give it a try. It's my impression that after studying your system for a while and studying my system for a while, and in fact meeting with a number of people today, that we actually have more in common than people usually say. And my theory about that is because we're dealing with the same organisms. And I don't mean those microbes, I mean us, both as patients and as participants in the healthcare system. And really, after a certain point, there aren't all that many choices to be made, but there are many challenges and difficulties in implementation to make improvement in our respective systems. I'm going to start with a bit of a story about my hospital, to give you the context, but before that to also give you a little story about myself to explain how I got here. I'm not trained as a physician or in any other aspect of medicine. I did my best through most of my life to avoid medical settings wherever possible, whether as a patient or visiting members of my family or friends at hospitals. I used to get anxious walking next to a hospital, much less going in one, and yet I find myself as CEO of one of the major academic medical centers in the world. My background is in public service for the most part, among other things running the Water and Sewer Authority for the Boston metropolitan area. Obvious good training for running an academic medical center. If you can make the connection, please tell me later. I have trouble making it. But in the course of various events, I found myself as dean of the administrative dean of the Harvard Medical School. The administrative dean of Harvard Medical School is basically the chief operating officer of the medical school. And in that capacity, I was in charge of the facilities and the library and the business matters of the medical school, and also was the liaison for the dean of the faculty with the Harvard-affiliated hospitals. Now, the way that system is constructed is a bit odd in itself. Harvard University has as one of its faculties the Harvard Medical School, which is a pretty good school, and for someone who's a graduate of MIT to acknowledge that anything at Harvard is pretty good is indeed a compliment. The affiliated hospitals with Harvard Medical School are several in number, Beth Israel Deaconess being one, Massachusetts General Hospital, Children's Hospital Boston, Brigham and Women's, and so on are others. But they are separate corporations from the university. And yet all of the physicians and the PhD researchers in our hospitals are members of the Harvard Medical School faculty, subject to the rules and regulations of that faculty, the promotion rules and so on, the conflict of interest rules and the like. But Harvard doesn't pay them. They are paid as a result of their clinical and research activities in our hospitals. By the way, I don't pay them either, in that they are not employees of our hospital. There's a separate faculty practice, once again another separate corporation, which resides at our hospital but has its own governing structure. And yet you can see there has to be a symbiotic relationship between the faculty and the hospital, or else it just wouldn't work for either one or the other. So during my tenure at Harvard Medical School, as administrative dean there, I came to know many of the Harvard hospitals very well, and in particular, soon started spending a lot of time and attention with Beth Israel Deaconess, which was going through a very, very difficult time. The hospital had recently been created as a result of a merger of the New England Deaconess Hospital and the Beth Israel Hospital. The New England Deaconess Hospital had been established in 1896 by the Methodist deaconesses as a missionary and social service hospital to take care of poor people and others in Boston. And 20 years later, in 1916, the Beth Israel Hospital was established by the Jewish community in Boston as a result of discrimination. Because at the time, if you were a Jewish doctor, you could not get privileges at the other hospitals in Boston. And in addition, the recent influx of Jewish immigrants from Eastern Europe were considered a bunch of odd-looking people speaking a strange language and dressing funny and eating funny. And they, in particular, were not welcome also at other hospitals in Boston. So the Jewish community started the Beth Israel Hospital in response to that discrimination, but because of that discrimination, opened up the hospital to people of all ethnic and religious and racial backgrounds and the like. And so the two hospitals, in a way, had a very similar set of values and a sense of mission to provide the best possible medical care to people in the Boston area, regardless of their racial background, their ethnic background, their religious background, and so on. And they also evolved to be academic medical centers, and the Beth Israel in particular, with a very, very strong research program and also a very strong teaching program, both for the medical students from Harvard Medical School and for graduate medical education, for residency and fellowship training. And in the mid-1990s, as a result of a structural change in the healthcare business in Boston and in much of the United States, the merger resulted. The idea of the merger followed on from a more powerful merger between Mass General Hospital and Brigham and Women's Hospital, which was designed to increase the market power of those two institutions, to give them greater leverage with the insurance companies in the state, to be able to negotiate better reimbursement rates, and also to obtain economies of scale and better access to capital for their facilities. The Beth Israel, although a Harvard hospital, was not part of that greater merger of the MGH and the Brigham, which resulted in an organization called Partners Healthcare. But the Beth Israel looked around and said, well, the Deaconess is right across the street. Why don't we merge with them and also create a network with some other hospitals? The result was a disaster. As many of you know from various walks of life, mergers which sometimes look good on paper often have trouble being implemented. And it takes a great deal of sensitivity and thoroughness to do these things properly. And while the Partners merger was a tremendous success, the BIDMC merger was not. And the reason for that was in the Partners merger, there was no attempt to obtain a clinical integration between the Brigham and Women's Hospital and the Mass General Hospital. Instead, the organizers of the system focused on business activities, on economies of scale, on contracting with insurance companies, purchasing and other matters, information systems, and left the two hospitals pretty much alone in terms of clinical matters. And the reason for that was pretty clear. If they were to have merged clinically, then say you had a chief of radiology at the Brigham and a chief of radiology at the Mass General. After a clinical merger, you would have one chief of radiology from one place or the other and one deputy chief of radiology from the other place. Not a plan designed to create harmony between the clinical structures. In contrast, the BID did just the opposite. Instead of focusing on the business integration, they attempted a clinical integration. And unfortunately, what was portrayed as a merger of equals, a true partnership between the BI and the Deaconess, was actually a takeover by the BI of the Deaconess, so that a year later, if you were to look at the clinical and administrative leadership of the new hospital, the new merged hospital, it was overwhelmingly run by the people from the Beth Israel. This created a great deal of animosity, alienation, anger, and the like. And doctors left, nurses left, lay leaders from the community left, referring physicians who had been referring to both hospitals stopped referring and started referring to other places. And the place went into a tailspin, a financial tailspin, and started losing many, many millions of dollars, tens of millions of dollars. And in paying for its operating losses, burned up about $200 million of a $600 million endowment. Now, as we have a term for this in business, and it's called not good. That's the highly technical term. And what a shame it was, because here you had two institutions which for almost 100 years had done very, very well, and really stood for what everything we would want academic medical centers to stand for. Excellent clinical care, superb research, and excellent teaching of the next generation of physicians, nurses, and other medical professionals. And it was about to disappear. It was around that time that I was asked to take it over. Why is beyond me. You could look at my resume and see the water and sewer experience. I also had been the regulator of electricity, gas, and telephone companies at one point in Massachusetts. I've been energy secretary to a fellow named Bill Clinton when he was governor of Arkansas. And there was really nothing in my background related to healthcare that would seem appropriate. But the board of directors, in a moment of clarity, decided, if that's what it was, in a moment of clarity said, well, we need someone who's a good manager to come in and run this place. And because I had been at Harvard Medical School, I was familiar with many of the chiefs of service at the BIDMC, and I had been getting along with them quite well, and so they all felt comfortable that I could do this job. So I did. I arrived, and I'm not going to spend any time tonight on the turnaround itself. It was a financial turnaround where our losses went from $70 million a year to plus $30 million a year within about 3 years, which once again in business terms is good. But to me that's not the interesting story. That's just a simple business turnaround where the basic rule is, in case you're ever involved in a turnaround situation, the basic rule is look at what the previous person did and do the opposite. Because if it failed, chances are it was wrong. And so do the opposite, it's likely to be right. But most of all, do something and just try it out. If it works, proceed. If it doesn't work, try something else. When you're in a turnaround situation and the place was within months of going out of business, it's much more dangerous to make mistakes of omission than commission, and you should always just keep trying and trying until you succeed. So we did it that. And the place became healthy and so on. Now, the next issue we then faced, having survived, is to decide for ourselves, in many of the ways that you are going through in your own city and country right now, trying to decide for ourselves what do we stand for as an institution and what are we trying to accomplish. And in particular, in our case, we were driven not only by our desire to stand for something and to accomplish something, but also by the fact that we live in a highly competitive environment in Boston with over half a dozen academic medical centers. And one could rationally ask the question of Beth Israel Deaconess Medical Center, if you didn't exist, what would we miss? What would be gone from the metropolitan area if you were not in business? By the way, a good question to ask of any institution. So we got to work on this, and we thought about it a lot, and we've decided that what we stand for is something that we think will distinguish us for years to come. Now here I have to take a little diversion and talk about our governance structure, because behind all of these organizations and influencing their path is indeed the important question of governance. In the United States, an academic medical center or most hospitals are nonprofit corporations. In a way, they're not owned by anybody. They're creatures of the state which has established general rules for the creation of public charities called nonprofit organizations, of which hospitals are one type. Our governing body is a board of directors, or in some cases a board of trustees, which is a non-executive board for the most part. So my board of directors has 18 members, of whom 14 are lay members from the community, business people and other people from the community. In addition to me, our chief of surgery, our chief of medicine, and the president of our faculty practice. In the old days, years ago, 10, 20, 30 years ago, people would join hospital boards for social reasons, to improve their status in the community so that they can serve on these boards, and frankly also to get better access for members of their family should they need hospitalization. Those were the two main rules. And they served with time and effort, and most importantly with money. They would donate money to be on these boards. In the new highly competitive environment of healthcare in the United States, the boards of directors now are more like corporate boards of the type that have to run steel mills and car companies and newspapers and the like, where the fiduciary obligations of those boards of directors are very, very important. Well, those boards have two major fiduciary responsibilities. One is financial, to ensure that the charitable assets that have been put at service to the public are used well and wisely, and in that regard they are supervised in our state by the Attorney General, the chief law enforcement officer of the state, who has supervisory authority over all public charities. And that's because these nonprofit organizations are given certain tax advantages. They don't pay income taxes, they don't pay property taxes. Donations given to them are tax deductible by the donors and the like. And so you need some public authority to oversee them to make sure they're carrying out their public purpose. In addition to that financial responsibility, though, the board also has ultimate responsibility for the quality of care that is offered to patients in that hospital. They have direct legal responsibility for that delivery of care. Now, this is an interesting issue, I think, because here you have a lay board of directors, people who might be good lawyers, administrators in other fields, community leaders, whatever, who are given responsibility for the actual quality of care offered in our hospitals. And what qualification? Ooh, where'd that come from? Well, there it is. Came up a little too soon. I'll get back to that in a second. That was my message to you this morning. Did any of you see it? Yes? Raise your hands. A few? Well, we'll have to change that. Tomorrow, more of you will read this. We'll get to that in a second. So one of the issues we faced with our board of directors, I'm going to turn that off so you don't get distracted. Sorry. Was how should they carry out this fiduciary responsibility? What indeed is their obligation, and how should they carry it out? And I'll return to that in a second, because the context of those discussions depended on what we, as the administrative and medical and research leadership, had already started to do in the hospital. And what had we started to do? Well, we had decided that the way we should distinguish ourselves in the Boston market was to be the high quality, high efficiency, or low cost hospital in the Boston area. When you're facing competition from large, well-funded competitors, which the Partners system is, you need to give the public a sense that there's something special about your place. And we wanted to create the impression, based on fact, that there was something special. Now, our hospital, because of that, maybe because of that religious heritage, already had a reputation in town as the most comfortable, warm, welcoming environment of the hospitals in Boston. When people come for care at Beth Israel Deaconess Medical Center, there's a warmth and comfort to the place which is different than what people experience in other hospitals. And I'm not suggesting that those hospitals don't do a good job. They do an excellent job. But the human interaction that takes place at the Beth Israel Deaconess is really quite special. People who've been to both our hospital and others often comment, "You made me feel welcome here. You treated me warmly. You treated me respectfully." Even the porters and the cleaners have this ethic. There are famous stories of a sick patient in a room in the middle of the night moaning, and a cleaner coming down the hallway mopping the floor, hearing the moaning, goes in and gently pats the hand of the patient, saying, "There, it will be all right," and then leaving quietly. And the next morning the patient saying, "Who was that nurse who came by to see me?" So there's a sweetness to the place that's really quite endearing and quite special. But ironically, many people, having experienced that sweetness and that niceness, said, well, they can't both be nice and good. If they're this pleasant to me, maybe medically they're just not as good as Mass General Hospital or Brigham and Women's. Now, there was no reason to think that, but people sometimes do. And we knew that based on the actual clinical outcome data that we'd looked at, that there really is an indistinguishable difference in terms of clinical care between Mass General and us and Brigham and us. But the public perception, if you go up to the person on the street and say, "What's the best hospital for clinical care in Boston?" people would usually say Mass General Hospital. And if you say, "What's next?" they would say Brigham and Women. And if you said, "What's next?" they would finally say Beth Israel Deaconess, just because of reputation. We decided to turn that around. We decided to not only pursue greater and greater quality of clinical care, but to let the world know that we were doing that. Now, in this task, I was aided by a newly arrived chief of medicine to our hospital, a man named Mark Zidell, who, interestingly, had been born at the Beth Israel 50 years ago or so, and spent some time at University of Pittsburgh, and we recruited him back. And Mark arrived full of energy, and the first thing he said was, "What's this? What are these central line infections? How come we're having central line infections?" And because he was looking at our statistics. And the response to him from the medical staff was, "Oh, we don't have a problem there. Our average number of central line infections, days, let's say infections per 1,000 patient days, is well below the national average. National average might be 4 or 5, and ours was at 3. And he said, "I don't care about that. It should be 0. Now, this was a striking thing to say, that being better than average was not good enough, that we should instead set an audacious goal and try to achieve that. And why did he do that? He said, well, if there are 4 cases per 1,000 patient days, and the mortality rate from every infection is 25%, which it roughly is, that means we're killing one of those people. So let's see if we can get the number down." And he got to work with it, and he called the group together, and he learned that the way that people had learned how to insert central lines was that the current crop of residents learned from the previous crop of residents, who learned from the previous crop of residents, and so on back and back. And that bad habits were being passed on generation to generation. And he said, well, we can fix this, and he pulled them together. He pulled together the senior doctors and the nurses and the residents, and he said, we're going to agree on the protocol that we're going to use for insertion and maintenance of central lines. They reached that agreement, and then he said, and now we're going to build a kit so that any time a central line is inserted, any doctor will reach up and pull out this bag, which will have everything in it that you need to do it correctly, along with the checklist of things that you're going to do, so that no one can ever complain, I couldn't get this supply or that supply or whatever. And here's what he said that was most important. He said, we're going to measure our results. We will, on a monthly and quarterly basis, report on how we're doing. We will chart it. We will share those results with everybody. And any time we have an infection, we will treat it as a sentinel event, and we will do a root cause analysis to see what caused it and what improvements we need to make. So he did that, and the rate of central line infections plummeted. Meanwhile, another group was working on the issue of ventilator-associated pneumonia, in the intensive care units, patients on ventilators were from time to time getting pneumonia. And there the mortality rate statistically is about 30%. And, but we know what to do about it. We know how to prevent it, or at least prevent most cases. And so he got the folks to start working on that. So I started writing a blog, which, as you may know, is just an online journal. And I started writing this because I thought I had a really interesting job, and the healthcare and medicine was also very interesting, and that people would be curious about what goes on in the healthcare field. And I started writing it, and people started reading it. And I would write about current events in the healthcare system, interesting issues that we had faced and the like. And it was getting more and more readers. And at one point I decided to start posting publicly the clinical results that we were starting to achieve with our various quality improvement programs. For example, the number of central line infections, showing the pattern of those over the years, over the months, telling people what we were doing and the like. Now, this is one of the few times that I didn't ask anybody's permission to do this. You know, as a hospital CEO, you generally don't get to decide anything. That some of you know. You really don't get to decide anything. Your major task is to maintain peace in the environment and try to slowly turn the tanker to go in a direction that's good for both the doctors and the hospital and the community. But in this case, I decided that what we were doing was important, and so I started posting those clinical results online. This produced, oh, and by the way, I also suggested to my colleagues around town at the Brigham and the Mass General that they might want to do the same thing. This produced a reaction that you might think is quite predictable. The reaction was anger, disdain, and worse. They said, "Who do you think you are, publishing clinical results like this and asking us to? You're not even a doctor." And saying things like, "This is bad for academic medicine. You're going to destroy the field." And worse. Now, in typical fashion, no one ever said this to me personally. Of course, you only hear these things indirectly. But nonetheless, I started posting these results. Let me give you an example of what I did. So in ventilator-associated pneumonia, there's a bundle of things you can do in the ICU that will help avoid VAP for a patient on a respirator. You can, for example, raise the bed 30 degrees. You can do oral hygiene. You can do several other measures, which are included in a bundle, as they're called by the Institute for Healthcare Improvement. And our folks got together and said, "We're going to do this." Now, I asked the question, how come we weren't doing it before? I never got a satisfactory answer to that, but I didn't want to push the issue because they were making really good progress. And this is a tracking of what they were doing, of the progress over several months. You can see compliance with that bundle. Now, on this one, as we say in our old exams in primary school, there's no partial credit for an answer here. You have to get all 5 of these items to be considered in compliance. If you don't have all 5, you're downgraded. So look at the compliance over the course of 5 or 6 or 7 or 8 months. Went from 70% up to basically 100% compliance, which was excellent. But here's the management insight I had when this happened. I started to hear from our people who were engaged in this effort the following. They sent me copies of emails they were sending to their colleagues, which went something like this. "You may have heard that Mr. Levy is writing a blog about things going on in our hospital. You might be interested to know that he's showing our clinical results for ventilator-associated pneumonia and the like. And this gives us an additional impetus, even beyond our desire to do well, to do better, because the whole world is watching." It was really interesting. Now, they weren't saying, and this is important in publishing these results, they weren't saying that we're in a competitive race vis-a-vis Mass General or the Brigham. They were saying, this is holding ourselves accountable to a standard that we have set for ourselves. Very, very, very powerful. And we decided as an institution, well, if we can do that on VAP, maybe we can do it for everything. So on our corporate website, we created something called the Facts at BIDMC. We're putting ourselves under a microscope. Now, this is not the first time that clinical data was being presented to the public on public websites. However, the clinical data that's generally presented to the public on websites in the US, and I don't know about here, is indecipherable and not useful and also out of date. It's usually based on administrative data that has been based on billing data that goes to Medicare, and it takes 2 years for them to post it, and most of the things they post are process measures like a person comes in with a heart attack. Did you talk to this person about giving up smoking? Did you give aspirin? Things like that, which are probably important in some way, but compared to not killing people in the ICU, right then and there, I think these are more interesting. So we decided to create a website called Putting Ourselves Under the Microscope. And here it is. Someday you can watch the video if you want. I'm going to turn it off now because you're seeing me live. And then under each of those, you can go through. We have a listing of topics. And here's the central line infection one, for example. It opens up, and it offers in plain English to the public a story about what are we measuring, why is it important, what is our performance telling us, and it gives the last quarter, and then most importantly, you can look at the trend here and see the trend over time. And you can do that on any number of metrics. Now, when we first started to put this out, once again, my colleagues at the other Harvard hospitals started to say, oh, they're just trying to make us look bad. Now, let's think about this. I'm posting numbers on how many people die in our hospital. And they're saying of me, I'm trying to make them look bad. I don't know if any of you are involved in marketing, but it is generally not a persuasive argument to say, come to my hospital because there's less chance you'll be killed. Right? It's not a persuasive approach. What are we doing here? We are saying, one, as I was saying before, we're holding ourselves accountable. But we are also saying to the public that part of our job as an academic medical center, which is supposed to be involved in pushing the envelope of quality and safety improvement and patient satisfaction, that you, the public, have a right to know what we're doing. And that we will be totally transparent to you in offering that information. When we get better, we'll tell you when we get better. When we get worse, we'll tell you where we're getting worse. And by the way, we'll also make an academic discipline of this. We will write articles about it. We will give sessions at academic conferences. We will promote our faculty based on the science of quality improvement, in addition to the science of cell biology or signal transduction or any other of the other basic science areas, that the science of quality improvement is as important to us as an academic medical center as the other biological sciences. And that one way we will make that be known is by publishing our data, doing it honestly and forthrightly, and currently, by the way. So, how does this fit into our governance structure? So having gone through this experience, we were then ready to pull our board of directors together and to say to them, okay, we've started here, but it's time for you as a board of directors to define the metrics by which you think we should be held accountable by the community. Not these discrete measures of central line infections and ventilator-associated pneumonia, But what measure would you want to say to your friends and neighbors in your community are going to be binding on us as a hospital so that you can tell them what we stand for? What is our underlying public obligation, and what public service are we trying to deliver upon? And they met, and we did a training session for them. We actually took them out onto the floors of the hospital where they could shadow nurses. They would go around and follow nurses and porters and other people, and they could see how interesting and difficult it is to actually practice medicine in real time with real people. And we said to them, we just want you to see that so you can see how difficult it is. We don't want you to solve the problems that the nurses and the porters are seeing, but we want you to understand what it feels like to be on the floors. And then the next step was to have them meet with patients who had been through both good and bad experiences in our hospital, to hear directly what went wrong and what went right. The next step in this retreat we held for them was to bring in Jim Conway from the Institute of Healthcare Improvement to talk about what they had learned about pursuing quality improvement and about governance of hospitals. And then their final task of this 2-day retreat was to go off into small groups and to report back and to come up with the 1 or 2 metric, audacious goal that they would want us to pursue as an institution that they would feel comfortable with as members of the community in terms of what we would stand for in the years ahead. And they came back. By the way, this was 2 boards of directors that did this, one for the BIDMC, the large academic medical center, but the other being a community hospital that we own, a 41-bed community hospital, small, to do the same thing. And interestingly, they came back with identical goals. And the goals which we have now adopted for our institution are twofold. One has to do with patient satisfaction. What's the experience like as you go through our hospital? What does it feel like when you call on the phone, when you show up at a desk, when the food arrives? All those things that affect the patient experience. And the goal they set there was that each of these hospitals should be ranked in the top 2% in the United States within 4 years in terms of patient satisfaction, based on statistically valid surveys that we all do for patient satisfaction. That's a big leap. Right now we're at about 12%. And to go from the top 12% to the top 2%, especially when everybody else is improving, is hard to do. But we're on it. The second thing they said is, we really, really don't think people should be harmed when they're in our hospital. People come to the hospital to be cured. And for them to be killed or maimed or suffer other kinds of harm is something that we want to avoid. Now, we know that not all harm is preventable. Some things just happen. However, we know also that there's a certain amount of harm that is preventable. And our goal is for you, the administration and medical staff of these hospitals, to eliminate preventable harm over the next 4 years. And then they said 2 more very important things. They said, we will be utterly transparent to the public as to our progress in this regard. We will set annual targets for both patient satisfaction and quality of care, and we will publish how we're doing quarter by quarter over the next 4 years for the world to see. Because we, the board, think the world has the right to know, and we, the board, based on the experience I just told you, think that as a management tool, that's a very effective way to motivate people. And just in case that wasn't enough motivation, the third thing they did was to say that the salaries of the top administrators, me and the vice presidents, and also the clinical chiefs, the chiefs of departments, would be based on achievement of those goals. Okay? This starts to sound like a business to me, more than a nonprofit in terms of these kinds of standards. But what the board was saying is, we're in business for a reason. We hold the public trust for a reason. We need to hold ourselves accountable for this. And the best way we can do it is by establishing very, very aggressive targets and holding people accountable and telling the world how we're doing towards this. So this is quite an adventure we're about to go through. You can imagine it for any of your hospitals or any hospitals you know. And I need to tell you that our people are incredibly enthusiastic about it. They are energized, they're excited, they're raring to go. Now, maybe one reason they're raring to go is because we all had a near-death experience together. The place almost went out of business 6 years ago. And we survived that. And going through that kind of near-death experience for an organization, as it is for an individual, is a very enlightening and inspiring thing in itself, once you've been through it. You say, wow, I was saved for a purpose. Not to get too religious about this, but I was saved for a purpose. What am I going to do with the rest of my life? And that's kind of the way our folks feel. Now, I would also be dishonest if I didn't tell you that there is a bit of competition going on here. Our folks are taking great pride in the fact that we've established these goals for ourselves and that we will be public in our progress towards them, because they notice that nobody else in town is doing that. That other people, in their view, are relying on their reputation, whereas we will be relying on our achievements to make our mark in the city. So, as I said, it's a fascinating story. I want to just show you one other item. Back to the blog a little bit here. Do any of you write a blog? Do any of you read any other than mine? Well, there's a lot going on out there in the world, in the world of social media. I know some of you are involved in Second Life. That's a different kind of social media, right? So it turns out that if you're running a blog, if you're writing a blog, you can attach to it this program that keeps track of how many people come and view it. So you'll see since September of 06, I've had 440,000 people visit this blog. Yesterday being Sunday, there were only 600. Today being a holiday in the U.S., there are only 500. By the way, today's President's Day in the United States. I'm reluctant to mention that in this country. But I'm told that there is a statue of George Washington in Trafalgar Square, but a smaller one than of the other gentleman. So here's the weekly traffic, about 9,000 or so. Now, the really interesting thing about this is you can actually see where people have come from. This is the last 500 people who viewed the blog. It's kind of a running total. It's kind of amazing, isn't it? Usually it's traffic from all over the world. I can drill down though and see. You can see there's a whole group from the UK. That's those of you who looked in. And then what's really interesting is you can also look at the ISP address, which is to say where the computer was headquartered. Here's the Imperial College group. But remember how I told you that when I first started doing the blog and so on, the result from other hospitals in the Boston area was one of disdain and anger and the like? Well, as we go down the list here, not to pick out any particular names. Oh, there's one. There's Harvard, and so on. It turns out that, and here's our biggest insurer, Blue Cross. It turns out that a lot of people in town are very interested in what we're doing. It also turns out that among the people who read this are reporters, journalists. And they write about what we're doing. Trade journals, universities, medical schools, and the like. So it turns out this as a form of communication and influence is much more important than I ever anticipated. When I began the blog, back in August of '06, I thought it would just be kind of fun and interesting to write. And now I find out it's a major communications tool. 10,000 people a week are reading this. Someone once said to me, "How much time do you spend doing this?" To which my answer was, well, if you could reach 400,000 people over the last year and 10,000 people a week, how much time would you be willing to spend doing that? What's one of the most important jobs of a CEO is communicating the values and the mission and the progress of the organization, both internally and externally. I can't think of any better use of my time right now, because I know I have an audience here of influential people, decision makers, who care about what we're doing. And so whether I spend 20 minutes on this in a day or an hour, it's time well spent. And because I'm not talking to a reporter here, and I'm not subject to an editor editing my words, I can put out the story in whatever way best suits my purpose at the time. It's a very, very powerful medium. You know, when I was first in public service, and a reporter would write a story that I didn't like, and I would get aggravated, and I would say to my press secretary, "We need to do something about that. We need to write a letter to the editor or complain to his boss about the way he wrote the story." The response I would always get back is, "No. He has more ink than we do. He has more ink than we do." What did they mean? Well, the next day, the reporter would be back and could write whatever he wants. And the next day, and the next day. Now, any one of us, I writing this blog, or you if you were doing the same thing, you now have as much ink as the journalists do. And you have it in a way that doesn't get edited. So it's a very powerful tool. I don't want to overstate its importance, except to say, particularly among the people in their 20s and their 30s, social media like this, like Facebook, like Second Life, are much more important sources of information and news and guidance than the newspapers, than television, and then radio. So as a communications tool, it's very, very effective. But as with any communications tool, unless you have something behind it that really is worthwhile and meaningful, it won't attract readers and it won't have any impact. So let me just conclude by saying this. I believe that the academic medical centers of the type we have in the U.S. and of the type you're working on here have great promise in the future healthcare delivery system, because the integration of the teaching mission, the research mission, both the basic research mission and the clinical research mission, the study of the science of delivery of care, as well as the actual delivery of care itself, can behave synergistically and can help produce a result that's better than we would have had before. And I would also state that as a matter of public interest and agenda and desire on the part of people that I've met in the medical field over the last 6 years, there's a real desire to want to do that. That people are kind of tired of being told that the medical system doesn't work, or it's too expensive, or I can't get the right care I need, or whatever. And that the people who've chosen to go into medicine, whether they be doctors or nurses or radiation technologists or whatever, tend to be very, very well-intentioned people who are devoting their lives to alleviating human suffering caused by disease. And our task, whether it's in my country or my state or yours here, is to help create the organizational framework that facilitates what they want to do anyway, which is just to take really, really good care of people and alleviating suffering for all the people in their area, whether it be a city or a country. So I hope this has been of interest and helpful to you. I know there are differences across the ocean and so on, but as I say, I think we're dealing with the same organisms here, and we have a lot to learn from one another. Thank you very much.
You've been listening to a special lecture vodcast from Imperial College London.